Hello, welcome to the Helen Bader Foundation CBRF Caregiver Training Program. This unit is on the management and administration of medications in the CBRF. This is Part 8, Medication Administration. We want you, the caregiver, to have a good understanding of how to administer medications. Now, I'm Maren Meyer. We've met in the previous parts of this unit. As you know, there are 8 total parts. Each has a video and a workbook. Be sure that you're reviewing the information that you've learned in the previous units. It'll make this information so much easier for you. As you recall, we start each of our parts with a pretest. The pretest and the post-test have identical questions. There's no grading. The questions on the pretest are to let you know what kind of information we want you to learn from the unit and to give you an idea of what information you already know. We'll review the answers when you take the post-test after this part has been completed. So right now I'd like for you to stop the video and complete the pretest and then come back. Welcome back. Now, I want you to feel free to take notes in your workbook throughout the presentation. Stop the video if you find that it is kind of dry information. So if you find you're not paying as close attention as you need to, stop the video and come back to it when you're feeling alert and ready to concentrate on it. In this part, Part 8, we're going to cover the information related to medication administration. Some of the topics are, first of all, we'll start with setting up medications. Then we'll cover some general guidelines for medication administration. We will talk about the all-important 5 rights in medication administration. We will go through a setup procedure for administration. We'll talk about keeping drug records. We have some samples of received and disposed of medications. We will discuss what happens when psychotropic drugs are ordered and administered to residents. And we have a sample of a documentation sheet for that. We'll provide you with some tips on how to keep the narrative or progress notes. And then we'll talk briefly about some other miscellaneous required records and how to keep all this just from becoming overwhelming. And we'll wrap up with a discussion on medication errors. So let's start with A, setting up medications. These are the basics about setting up medications. All meds in the CBRF require an order from a physician. They have to be ordered then and received from the pharmacy, stored in proper containers and in the proper locked area. The medication area where you're going to be storing your medications should be clean, it should be in a quiet area, and it should be free from noise and distraction. You certainly don't want to have your medication area in the most highly traveled part of the facility. It needs to be well lighted. And you need to remember that it's so important that an error could really injure a resident, that locating the med area is something that you don't just sort of do haphazardly. Well, here's a closet, we'll put a lock on this. You want to just take your time and find the perfect spot for it. That's because you need to be able to concentrate and be alert to what you're doing. When you're setting up medications, what you're doing is you're taking information from the medication administration sheets and you're actually preparing the dose for the resident. And you need to then be conscious of all the errors that could possibly occur. I'm going to go through most of what we have listed under B. Not because you couldn't read it, because I'm hoping you will also read it, but because this information is just so vital to the well-being of your resident, of you as a professional, and of your facility. First of all, any time that you have instructions that are not clear, consult the physician, a nurse, or the pharmacist. When you prepare medications, be sure you focus just on what you're doing. Concentrate your entire attention on it. Don't talk to other people while you're doing it. And never leave your medication cabinet unlocked or unattended. Be sure you have a physician's written order for every medication that is going to be administered. If a medication appears different in any way than what you expect, always consult the pharmacy. Always check to see if medications should be given with food or on an empty stomach. Only give medications from clearly labeled containers, and never give a medication from an unlabeled container. Don't administer medications that have been prepared by someone else. Don't touch the meds with your hands. Don't permit one resident to transfer medications to another resident. Never leave at bedside any medications or at chairside. And never force a resident to take a drug. Now, there is a temptation, back to number 13, to leave medications at chairside for somebody who's, say, watching their favorite show, and they say, oh, I'll take it at the break. Don't do that. It's not that you can't trust them, and you can explain this to the resident. It's that another resident who may not have the reasoning ability may just pass by and take that medication, and it could cause them serious harm. So I think a lot of times your residents who are very capable and want the medication left will understand when you explain to them that it's not just a stupid rule, it's a rule to protect not just you and them, but also residents who are less capable than they are. Don't record medications before they're given, but do record them as soon as they've been given. You need to know some basic abbreviations for both medications, for doses, and for administration orders. If you're in doubt, always look something up or ask. And any error that you think you've committed or that any error you made needs to be reported immediately. Most of the time errors are minor, but a lot of times the person making the error is not in a position to make that determination. So you need to immediately report it as accurately as you can. Let's go to C and talk about the 5 right things that are involved in medication administration. The rules for giving meds are the same. It doesn't matter if I give them, or if a nurse gives them, or if a physician gives them, or if a non-medically licensed staff member gives them. You always use the same approach and the same steps. It's the only way that you can ensure that you give the medicine to the right resident, you give the right medication to them, you give them the right dose, you give it at the right time, and you give it by the right route. So we'll go into a few specifics about each of these 5 rights. When you do a med pass, don't rush. You have as much time as it takes. If you find that your medication pass is going to take longer and would make you be late in administering a medication, then it's important to get those medications rescheduled. Talk to the pharmacy about it, because rushing is a sure way to make mistakes. You need to identify the right resident. We talked about this in another part of this unit. Always identify the resident in some way. Make sure you know who that person is. The photo ID system that some facilities use, I think, is great, because if I went in to do a med pass, I would have a very difficult time identifying residents who suffer from dementia, for example. And if I had a current photo that was attached to their medication record, it would make things a lot easier and more sure for me. If I wasn't sure, I would get another CBRF employee to help me. And then you check the resident's name against all the records that you're using. You would check it against the label, against the medication records, and against what the resident says their name is. You want to administer the right medication. You only want to give the medications from the pharmacist labeled container. You want to keep medications in those little pods and open them only when you're ready to actually administer them. So you don't set up a bunch of medications in advance. When you are ready to administer the medications, then you would prepare them. You need to read the labels 3 times minimum, okay? So you read the label as you take it from the drawer or the shelf where it's stored. You read it as you measure it or as you are opening it up. You read it as you replace the bottle, or if you're going to discard a package, a unit dose package, then a lot of people reread that package just to make sure they got the right drug and the right dose. Beware of drug names. The drug names are notorious for being very similar. We've given you an example here between Oronase and Oronate. One is a nasal decongestant and the other one is for diabetes. And giving them in error could be really catastrophic. So be very cautious of the spelling and any abbreviations that might be used with drugs. You need to know the abbreviations of various drug types. For example, solution or cream. Cream is CRM, for example. And we gave you a sheet that listed those in a previous part of this unit. If you're not sure, check with somebody. If the resident says, no, that's the wrong stuff, trust the resident. If anybody says that doesn't look right, assume they might be right, okay? So check it out. Be sure that the label, the name on the label matches the name on the medication administration record and that matches the name of the drug that's on the medication packaging. The third right is the right dose. You want to know the correct dosage symbols. I personally believe that CBRFs should be writing things in plain old English. Some do, some don't. If your facility uses the Latin abbreviations, then you need to know those and know them cold, because an error with dosing could easily be made. Check and make sure that you have the correct type of measuring device and that you know how to use it. You know, you aren't genetically predisposed to know how to use one of those oral syringes, so have someone help you practice in using those. If you aren't sure that you have the right dose, check with somebody else. Make sure that the amount that's stated on the label is the amount that's also stated on the medication record, because it is possible to make a transcription error there. And you want to be sure to stay with the resident until the resident completely consumes the medication. That means until the medication has been swallowed and followed by 3 to 4 ounces of liquid. The fourth right is the right route. Be sure you know the correct abbreviations for routes. If you're not sure, check. And it is possible that if someone has printed these things by hand, that they look similar. For example, PV means vaginal and PR means rectal. Now, depending on how good your printing is, that V and R could look very similar. So if you're not sure, clarify it. You need to be aware that changes in a resident's condition can affect what route of administration they're receiving the medication by. Now, some examples of times that products would be used by a route that doesn't seem reasonable but is, one example is gentamicin eye drops, which are very often ordered to be used in the ears. And unless you know those abbreviations, you might accidentally use the eye drops in the eye because they are labeled eye drops. So never guess, always clarify the intent of the medication and know your abbreviations. The fifth right is the right time. Here again, you need to know the correct abbreviations. Check and make sure that you're giving the medication at the right time. A good idea is when you come into work, look through all the medication records and find out when your med passes are going to be. That way you can organize your time so that you have time to to not rush as you administer medications. And again, never leave a medication with someone for them to take it later. Always, before administering medications, check to see whether they're supposed to be given with food or on an empty stomach, because that will affect how effective the medication is. On D, we have for you a poster of the 5 rights, and I would hope that you would use that and review this information. Be sure that after you do the 5 rights, you do the 6th one, which is document that you gave the medication. Let's look at E. E is the procedure for a med setup. Number 1, wash your hands for 20 seconds. Unlock the medication cabinet or cart. Prepare the medication drugs for 1 resident at a time, and only 1 resident. Identify the right resident's name on the drug administration record. Identify the right resident's individual storage drawer, bin, or area. Identify the right med container while removing it from the bin or drawer area. Check the drug label with the drug administration record for the right resident, the right drug, the right dose, the right time, and the right route. Check the expiration date. Place the drug in a clean, disposable med cup. If you're using unit dose, place the unit dose container in the clean, disposable med cup. Don't open the container until you are actually administering the medication to the resident. If you're using a tablet or capsule bottle, pour the prescribed number of tablets or capsules from the bottle into the bottle cap. From the bottle cap, pour the prescribed number of tablets or capsules into a clean, disposable drug cup. Again, check the medicine label with the drug administration record and make sure that you have the right resident, the right drug, the right dose, the right route, and the right time. Take the medicine to the resident at the correct time. Identify the correct resident. Administer the medications to the right resident. Remain with the resident until each drug is swallowed. Wash your hands. Record each drug given on the medication administration record. Return to the resident within 30 minutes to evaluate the response to the drug or medication. Under F, we have drug records. Now, if the owners or managers or caregivers have any questions regarding the use of psychotropic drugs in their facilities, they should feel free to contact their licensing specialists. Here we have a review and a reminder about the records that you need to maintain regarding psychotropic meds. First of all, you need an assessment of drugs or meds that are going to be taken and the resident's ability to control or self-administer those meds. If the CBRF identifies that the individual is not able to self-administer medications, they're going to need a written statement, and that information is in our previous part. It'll be an order from the physician for the CBRF staff to administer the meds. A physician's order has to be obtained before any medication is taken or administered to a CBRF resident. The records that you need to keep for CBRF residents, regardless of whether they're prescribed or over-the-counter medicines, have to include the resident's name, the name of the medicine, the dose, the date and time at which the medicine's to be given, the route by which it's supposed to be given, the initials of the staff person who administers it, any changes in condition, and any comments that the resident makes. You see this is starting to fit a pattern. Once you get those 5 rights and the 6th one of documentation in there, it becomes a lot easier to do this. It seems a lot more manageable. I would also suggest asking residents who self-administer to keep you informed of any frequently used OTC medicines that they have As you recall, frequent use of OTCs can indicate either a treatable or a new possible serious condition, or the OTC medication may be masking symptoms of some kind of a condition. So you need to ask your other residents, the self-administering residents, about their medicines too. Under 4, records for all medications administered on a PRN basis. This is straight from the rule. What you have to have on the medication administration record is the resident's name, the name of the drug, the dose, date and time, the route, your initials, any change in condition, comments about the condition from the resident, why the resident received the PRN or as-needed medication, and what was the outcome of that medication. Under number 5, records of receiving and disposing of medications. You need to keep those. We gave you a sample form in the last part. Number 6, records for medications returned to the pharmacy. There should be probably none of those, but if you do have some system by which you return medications, you need to keep a record of those. We have samples for you under G, H, and I of medications, the disposal, receipt, and return policy. Under J, when psychotropic drugs are being prescribed for a resident in a CBRF, the CBRF needs to do these things. First, they need to ensure that all staff who will be working with the resident or administering that medication are aware of both the benefits and risks of those medications. They need to have that education. They also need to ensure that the resident is evaluated and re-evaluated at least every 3 months to see if the desired responses have been obtained, to see if there are any side effects, and to determine what kind of recommendations you would make to the physician regarding maintaining the dose or decreasing the dose, for example. They also need to document the actions that are required in the medical record. And here we have the example again. Now, I want to just go over this information one last time. Since this is our last part of this unit, I want to be sure that you've got this one down cold. If you are documenting on a particular behavior, what you would do is you would have 2 boxes under each date of the month. And in the upper box, you would record how many times a certain behavior occurred. And in the lower box, you would record your initials. So if on my day shift I saw hitting 4 times, I would put 4 in the upper box, and I would put MM underneath that for my initials. Throughout the unit, I've been talking about progress notes. Now let's take a look at what progress notes are and how we can keep them from sort of getting out of hand for you. These can be kept pretty easily as long as you follow a few easy rules. What they include are events, incidents, adverse drug reactions, transfers, discharges, or any change of condition at all. And those things should be recorded in the progress notes. To make progress notes, what you do is you always date the progress note. And generally, you would also put a time there. You record the facts, okay? If you're going to give an opinion, you need to say, in my opinion. So you want to label opinions. If you're going to include that, certainly tell that it is not a fact. Keep it brief and to the point, just the facts, ma'am. Be specific. Don't leave gaps in between progress notes. If your progress note doesn't completely fill a line, draw a line over to the end and then sign your name. If you make an error anywhere on any of the patient records, including the progress notes, you don't erase. You just draw a line through it, you write error, you initial it, and then you write the correct information. Write in pen, not in pencil. These are permanent legal records. Always write legibly. I know there are people with degrees who don't, but we're trying to set a good example too, and illegible notes are utterly useless to the next person who might benefit from using them. Always use either the correct abbreviation or symbol, or use plain English. Record anything that seems important to you or to the resident. Residents' records are always confidential. Remember that, okay? It is okay to ask another staff member, well, how do I say this in these notes? But just to discuss the condition, just to be discussing it, is not appropriate. And if you aren't sure about how to chart, or if you're feeling a little uneasy as you get started with charting, go ahead and ask your supervisor. Under M, we have some other miscellaneous records that are required. First of all, every CBRF has to have a record or a chart for each resident. And the access to those charts or records is restricted either to the resident, the staff, or the resident's representative or guardian. The resident and the resident's guardian or representative need to be informed that they do have access to those records upon request. Under number 4, we have a blow-by-blow list of all of the information that needs to be included in the resident's record. This is taken straight from the rule at 83.18. Some of this is real obvious, and some of it is a little less obvious. Besides the person's full name, sex, birth date, and social security number, there are things like, in the past, you had to have an individual's medical and social record, but now you need to include, where applicable, any psychiatric history, if that applies. You need the results of previous assessments. You need incident reports and illness reports. You need a copy of the ISP. Go through this carefully and make sure that you have a section in your resident record for each of these items. Grievances, hopefully that'll be an empty section. But you need to remember that these are required parts of the record. Because of the variety of needs in CBRFs, the administration records under N are going to vary from one CBRF to another. And that's fine. There are some records that have to routinely be kept. And that includes the medication administration records. And those can be referred to as MARs, which is medication administration records. Some people refer to them as med sheets or med records, and some people call them the med chart. That basically means the same thing. It's the history of medications that have been administered or have been refused or held or omitted for some other reason. The information that's required by HFS 83 is listed under N3, and we're going to go through this in just a minute. Be sure that you've got all of these things on your administration records. You don't have to use some standardized form if you don't want to, but you do need to have an area to include all of this information. Now, with your medication records, a lot of you are working with pharmacies that are already providing you with a monthly printed medication administration record, and they may also be providing drug information, or they may be providing printed physician's orders. We're going to show you a printed medication administration record. Most of the pharmacists are going to group drugs in this way. They'll list first the scheduled medications, then the scheduled treatments, the PRN medications or the as-needed medications, the PRN treatments, and then miscellaneous items, for example, nutritional supplements. The drug records should never be written on, changed, or altered in any way without prior authorization to do so. And if, for example, something was discontinued last month and yet it still appears on this month's record, that would be when you would might either draw a line through it, date and initial it, and right next to it say discontinued on April 28th, or you would yellow it out with a yellow marker if that's the policy of your facility, but you would never erase it because it is a legal record. We're going to show you some samples of medication administration records, and what I'm going to do is just tell you a little bit about these. You've probably seen them a million times. I don't want to bore you with it, but I want to make sure that you see all of the features that you want to be including in your own records. Okay. Here we have a sample of a resident's med record. And first of all, we have the name of the document. So we know that this is a medication chart, which is what I call a medication administration record. We have the name of the facility. In this case, it's Happy Days CBRF. We have the name and telephone number of the dispensing pharmacy. This is Galash Pharmacy. We have the resident's admission date. We have the resident's name, which is Emma Jones, and her room number, the date of birth and sex of the resident, which is both at the top and at the bottom of the sheet, the month and year of the medication administration record, the resident's identification number, which here we've given her the number 012345, and that can be the pharmacy's identification number or the CBRF identification number. That's also at the bottom of this page. We've color-coded for each shift of caregivers that are going to be administering medications to make things easier. We've included the diagnosis of the resident in the lower left hand of the page. And you see this individual has dementia, CHF, hypertension, angina, and diabetes. The residents' allergies are there, and you see that we've drawn a red line underneath that, both to keep the physician from ordering medications that the resident could be allergic to, and to keep caregivers from accidentally giving something that the resident is allergic to. We have a blank space on the right there. Maybe you could put in a resident contact, relative. We have the resident's physician's name and address, and the resident's physician's phone number. Finally, we have the physician's DEA number, which is on page 1, is the BW1357931. And we have the page number, because some residents have, as you know, more than one page of medication records or charts. We use the generic name of the drug. Try to familiarize yourself with the generic names. If your resident is using brand name products, for example, K-Dur for potassium, ask your pharmacy to list both of these. We have the dose that the medication is going to be given at. For example, we have furosemide. The dose is 40 milligrams, 1 tablet, so that means 40 milligrams. Then you have the dose of the medication that's going to be administered. For example, here we have Captopril, 12.5 milligrams. This is on page 1. Always make sure you understand the directions that are given for the med. It says take half a tablet by mouth. Well, if you have the 12.5 milligrams and you're supposed to be giving 6.25 milligrams twice a day, are you supposed to break the tablet in half? What are you supposed to do with the other half if you do break it in half? Call your pharmacist, ask for clearer directions, and request that those clarified directions are printed onto the med chart the next month. We have the date through on which the medication or treatment is to be given, which is the squares 1 through 31. Sometimes you won't use 31, and in February you won't use 29, 30, or 31. You put X's or lines through the dates the resident is not going to be receiving the drug or the med or the treatment, and that will help prevent you from administering a drug on the wrong date. And a good example of that would be if you have somebody who receives medicines every other day, you would put an X on the days that they are not supposed to receive medications. The times at which the drug is supposed to be given, for example, in pink for the furosemide, the K-dur, and the glipizide, at 8 o'clock. You've noticed that we've done all the day meds in pink, the PM meds in green, and the night meds are in blue. And we've got those coded down on the left lower part of the med chart here. We do the highlighting to help the caregiver keep from administering a medication that was given earlier or is supposed to be given later. We have the route that the medication is to be given by, and we have the date that the medication was ordered. For example, 4/22/97. We have the reason that the medication is being used. That's the indication, if you recall. In this case, we're using the furosemide, or Lasix, for congestive heart failure. It's always important to know why you're administering drugs, because then you have an idea of what kind of side effects or what kind of results to expect. We have also the drug precautions or additional instructions for administering the medication. With the furosemide, we have take with food or following meals. With the glipizide, if you find that, we have take with breakfast. The potassium chloride, take with plenty of water or food or milk. The digoxin, hold if pulse is below 56. The captopril, take on an empty stomach. The nitroglycerin skin patch, remove patch each PM. The risperidone, indicate how many X's or how many times the agitation was observed on your shift. Loperamide, which is on page 3, don't exceed 16 milligrams in 24 hours. Also on the PRN page is the nitroglycerin. Notify the physician if the resident continues to have pain. The Eucerin, use as needed and apply to dry skin. The Citracel, up to 3 times daily as needed. And the glucometer, notify physician if fasting blood sugar is greater than 160. We always have the initials of the staff person who is administering the med or drug, and that is put in each square of the month next to the administration time. Each CBRF needs to have an initials identification record. This can be a separate record. It's easier to do that, and then you would put a copy of it in each resident's chart. What that record has is each staff person's initials and their signature. That gives us a record of what initials they're using and how we identify them. Sometimes people substitute initials other than their own, and it may be because there are initials that are just like theirs. For example, if Mary Miller also worked at this facility, then I, Maren Meyer, might want to use a different set of initials. Another reason would be if your initials are another common abbreviation. For example, DC means discontinued, and BM also means bowel movement. So that initials identification record is a vital part of your records. We have a discontinued medication here in the PRN section on page 2. We've highlighted it. Here we've used yellow, and that yellow is designated in this CBRF to designate when a medication has been discontinued. When drug treatment is discontinued, it should be entirely highlighted in the designated color. It needs to be signed and dated, and then you need to put DC'd or discontinued. So you have to have a reason that you've yellowed that out. When a staff person sees the treatment that's entirely highlighted with the designated discontinued color, it's going to save the staff person a lot of time. They can just skip right over that. Entirely highlighting, dating, and signing the med that's been discontinued prevents a lot of errors. PRN medications are underlined in red here. Now you can do this any way that works best for you, but the point is to draw attention to the fact that they are not scheduled medications, that they're given only as needed. They can only be given within the guidelines that are specified by the physician, for example, every 4 to 6 hours. PRN medications are initialed on the front of the med administration record by the caregiver who administers them. The resident's medical condition for receiving the PRN medication has to be indicated and documented on the back of the administration record. So on the back, you'll find the date and time the drug was administered, your initials, if you're the caregiver administering it, the name of the drug, the dose of the drug, the reason it was administered, and the results or outcomes of administering the product. Sometimes drugs or treatments are not given, or they aren't given by CBRF staff. And in these cases here, we've used the examples H for held, where the physician's order said that it should be held for a dose. For example, if someone's pulse was below 56, you would hold the dose and you would put an H in that area. Or if the resident refused, you would put an R. You might use O for outing or O for other. What you need to do is standardize these for your CBRF and don't use non-standard abbreviations. The documentation of drugs that are not given or drugs that are not given by the CBRF staff should be documented in this way. You initial the box using your standard initial of H or R or O. And on the back, on the PRN section, you put the date, your initials, what the drug was, and the dose, and the reason that it was either held or refused or other. For example, for an outing, you would write that the resident went on an outing to the doctor or to the daughter's house, and you tell to whom the drugs were given. In P, we've provided for you a poster to help you with administration of nitroglycerin topical. Under Q, we have medication errors. Unfortunately, it is something we need to talk about. We're all human and we are subject to error. There are a lot of actions that we take all the time, especially as caregivers, that may lead to a medication error. What we want to know is how to prevent them, what to do when they occur, and how to report them so that we protect the safety of the resident. First of all, what do we consider a med error? That would be giving a med to the wrong resident. It could be giving the wrong dose. It could be giving the wrong drug. It could be giving a drug by the wrong route. So any of your 5 rights that get violated here would constitute a med error. It could be giving it at the wrong time. It could be forgetting to give a resident a medication or just completely omitting one of the pills. It could be giving an expired medication or using an expired topical or eye drop. It could be crushing or breaking a medication that's not supposed to be crushed. It could be not shaking a medication like an oral liquid or a bottle of NPH insulin. And in some respects, you have to consider failure to document administration as a med error, because without documentation, we don't know if the medication was omitted or if it was indeed given. What do you do if you think you've made a med error? The first thing is you always need to have a written procedure in your facility that tells everyone how to proceed. Laying blame is not the purpose here. The purpose is to protect you as a caregiver and to protect your resident. So you need to have a policy and procedure and you need to follow it. The first thing is you immediately report it orally to your supervisor, to the person who's in charge, and follow their directives. The next thing is that the error needs to be recorded in the progress notes or the narrative part of the patient's or the resident's chart. And each CBRF needs to have some kind of an incident report or a med error form that needs to be completed every time a med error occurs. There's a purpose for this other than just making you look bad, okay? Telling the truth about a med error can keep it from becoming a catastrophe. Sometimes you'll feel so foolish about what you've done, you just won't want to tell. But it is very important that we know exactly what happened. And one of the reasons is that by reviewing what we do when we make errors, we can sometimes change the system that allowed us to make that error so that no one else makes the error, or so that we don't make it again. So correct reporting and prompt reporting is very important. Why do med errors occur? Well, just sort of comes with the territory. Sometimes the physician's orders weren't copied correctly, or they were copied incorrectly, and then whoever checked them wasn't checking very carefully. Sometimes there wasn't enough concentration used in the setup of the meds or in the administering, or your attention got distracted. There are a lot of things that can cause a med error. Medication errors can be extremely serious, and even making a minor error is something that you shouldn't beat yourself up about, but you do need to take a very hard look at how it happened so it won't happen again. So in documenting medication errors, the HFS 83 says that all errors or adverse effects, as soon as they're identified, shall be reported to the prescribing physician as soon as possible, and these facts will be documented in the medical record. Now, you need to have each of your prescribing physicians specify what they mean when they mean as soon as possible, so that you aren't calling them in the middle of the night if they don't consider it that as soon as possible. So it's just something you need to clarify and have written in your chart. Your conversations with the physician about how soon to contact them needs to be documented very clearly in an accessible place in the chart. And you might want to put that at the beginning, say, of the physician's orders. Wherever it is, it should consistently appear there so that everyone knows if they need to contact a physician as soon as possible, what does that mean and where do they find the physician? At the bottom of this page, then, we have another reference to the guide for your pharmacist and for you on the rule and on learning about CBRFs. You probably know lots about CBRFs, but I imagine some pharmacists don't. We're going to end Part 8, Medication Administration, with the post-test. As you know, the post-test is the same as the pre-test, and I'm hoping that you will get 100% of these right. So at this time, I would like for you to stop the video, complete the post-test, and then come back and we'll talk about the answers. Welcome back. So let's talk about the answers here under Part 8. These were true and false questions. I'll read the question and then I'll tell you the answer. Number 1, the drug area in which drugs are set up should be clean, quiet, and free from distractions. The answer is true. Number 2, if a drug instruction is not clear to you and you're unable to contact the CBRF's nurse, you would contact the pharmacy that dispensed the med. That's true. Number 3, the right resident should be given the right medication in the right dose by the right route at the right time. That's true. And I imagine you'll be able to say this one in your sleep pretty soon. Number 4, it is not necessary to know standard medical abbreviations when administering medications. That's false. Be sure to clarify any odd-looking abbreviations also. Number 5, before giving any drug, you would check to see if it could or should be given with food or on an empty stomach. That's true. Number 6, the CBRF shall keep records of all drugs administered to any resident and all drugs received, disposed of, and sent back to the pharmacy by the CBRF. That's true. Number 7, psychotropic drugs are documented just as any other drug is documented in the CBRF. That's false, and now you know which forms you can use. You know the extra information is being documented to ensure safety of these medicines. Number 8, crushing or breaking a drug that is not meant to be crushed or broken is not considered a drug error. That's false, and you would need to complete the appropriate paperwork on that. Number 9, a resident's refusal to take a drug shall be reported to the prescribing physician as soon as possible after the resident refuses the medication for 2 consecutive days. That's true. Number 10, all drug errors and adverse reactions, if known, shall be reported to the prescribing physician as soon as possible. And that is true. Now be sure to review all the information in these units. Keep your workbooks as references and resources. Be sure you have a good drug reference. And I want to thank you for being part of this unit on medication management and administration in the CBRF. I hope the information is useful to you.